Hi, my name is Randy Lee, and first I want to thank SAEM for allowing me to present my research. I also want to say that I don't have any disclosures. So my research project that I'll present today is called The Utility of Pulse Oximetry in Diagnosing Respiratory Illness in Pediatric Patients who present to the emergency department. To give you a little background, there's 30 million pediatric patients who present to the emergency department every year, and about a third of those are related to respiratory illness. Pulse oximetry is often used when patients first come to the emergency department to get a sense if there's an abnormality in their oxygenation. And we're really checking to see patients that have an unexplicable abnormality, as in if a patient comes with respiratory distress, it's usually relatively easy to see that they're in distress. But if the patient comes in and have an oxygen saturation of 90 and that's unexpected, those are the children that we're trying to pick up with the pulse oximetry. And while there's been a number of research projects that have looked at the bell curve and also distributions of oxygen saturations of both children and adults, there's no study that has attempted to try and create a cutoff of what is normal and what is abnormal in a healthy child. Our primary objective was to determine what the lower oxygen saturation cutoff would be for a normal child, and then use that cutoff to discriminate between both normal children and children with respiratory illness. And our secondary analysis was to look at the receiver operator characteristic curve and its performance under the optimal cut points that we've determined. So the methods of our study, we did a prospective observational study. It was done in two hospital centers, one academic tertiary center, and then a second semi-rural hospital, both located in Los Angeles County. And how we did the study was for every child that came in that was under 11 years old, after the patient had been discharged, there were volunteers that would go up to treating providers and ask the provider what the diagnosis was of the patient. And then we bucketed those diagnoses into either non-respiratory or respiratory illness. And if it was a respiratory illness, then the provider could choose one of a series of subgroups for respiratory illness. Our outcome was the optimal oxygenation saturation cut point for normal children. And we used two different analyses to determine this. One was Youden's index based on a receiver operator characteristic curve. And then secondly, we used Shannon information of a diagnostic test to determine the point of extrema. So in enrollment, we looked at all kids under the age of 11 years old between 8 a.m. and midnight for a year period between February 2019 and February 2020. That was about 3,500 kids, and then 133 were excluded for a different physiology or illnesses or disease that would cause them to have an abnormal respiratory illness that would not represent what would be a normal child. Here are the results. This is the median and then the 25 to 75% quartile. The reason why we chose medians versus means and standard deviation is because we did not see a normal Bell distribution. So therefore a median with the 25 to 75% quartile would be a better determination of what would be the range of these children in different diseases or different illnesses. Here is our receiver operator characteristic curve, which shows a Youden index is maxed at 98%, signaling a cutoff point at that level. The area under the curve is 0.70, which which shows it's a relatively poor diagnostic tool to determine if a patient has respiratory illness. Here's our second analysis. This is a Shannon information of a diagnostic test, which shows a point of inflection at 98%. And that will signify that there's an optimal diagnostic cut point at that level at 98%. We had several limitations of this study. Oxygen saturation levels are obtained at sea level. As you increase the altitude, your oxygen saturation could be decreased. The skills of the emergency medicine providers determine the diagnosis. In some cases, residents were the ones to make the diagnosis of the patient. And at certain levels of residency, residents might struggle to determine if someone has respiratory illness or not. The clarity of diagnosis at discharge, sometimes patients did not have a clear diagnosis at discharge if they went to the ICU quickly, or if there are other situations that a diagnosis was not made, then those patients might not have the most accurate diagnosis. Our study had an abnormally large Hispanic population, it was about 40%, and we excluded kids above 11 years old because at that at that age, kids start to develop kids' vital signs normalize to what would be expected in adults. And that's for both heart rate, blood pressure, and we assume it would be the same for oxygen saturation. So in summary, both Youden's index and Shannon information theory indicate an optimal cut point at 98%, which would be the level at which, or a level below which, would be abnormal in healthy children. And then we looked at the area under the curve, which shows a very flattened ROC curve, which would signify that respiratory illness cannot be excluded in children who present with oxygen saturations at or above 98%. So to summarize, children with oxygen saturations below 98% is not normal, but if a child has an oxygen saturation greater than 98%, that still could, or the patient could still suffer from respiratory illness. So I want to thank my co-authors and other influential people in our emergency department, and that's it.